Good afternoon, everyone. My name is Holly Starling, the Program Manager of Member Services and Special Projects at the Center for Healthcare Solutions. Welcome to our special webinar offering presented by Grane Rx and Access DX. We are joined today by Rick Shigaki, the VP of Pharmacogenomics Solutions with Access DX, and Jen Devinney, the Chief Clinical Officer at Grane Rx. Rick has been working in the healthcare industry since 1993, holding various positions in marketing, analytics, operations, and business development. He has spent the last 10 years implementing pharmacogenetic programs and technologies in different care settings to include various pharmacy solutions. Currently at Access DX, he leads a team dedicated to the clinical adoption of an evidence-based pharmacogenetic solution in order to improve patient outcomes. Jen Devinney has been the Chief Clinical Officer of Grane Rx since 2014 and has spent her career primarily working in a long-term care pharmacy. Her depth of diverse experience has fostered expertise in operations, workflow refinement, data analytics, medication therapy management, and much more, all with the aim of contributing to the improvement of patient care in the geriatric population. Jen Devinney is committed to the practice of utilizing the best possible tools to enhance medication therapy management and create positive outcomes for seniors. So, without further ado, here is Rick and Jen on pharmacogenomics across healthcare settings.
Thank you, Holly, for that warm introduction. Welcome, everybody. Thank you for joining us today. Recognizing that there may be varying levels of experience with the topic, we're going to be speaking at a higher level today. Pharmacogenomics is an in-depth area, so we can easily go well beyond our allotted time this afternoon if we get too detailed. We also realize that there are a variety of care settings represented, so we want to show how this topic is applicable across the continuum of care. Next slide, please. This afternoon, we'll be focusing on the importance of genetics in prescribing, as well as how pharmacogenomic tests can be used by providers as they are caring for patients. We will also touch on pharmacogenomic testing in diverse care settings. The Center for Healthcare Solutions has a diverse membership, and this is a subject matter that can easily touch the care settings that are represented. To demonstrate the impact of pharmacogenomics, we will be reviewing 2 patient case studies. In these examples, pharmacogenomic test results were not initially available to the provider. We will see how the outcomes may have differed if pharmacogenomic test results were available to leverage during prescribing. Throughout the discussion, we hope to provide a glance at where we are today. To close out the discussion, we also want to take a look at the future to see what potentially lies ahead in this field. Next slide, please. So let's go ahead and dig in. Many of you may be asking, what is pharmacogenomics? It is also commonly referred to as PGX. Pharmacogenomics is the study of how a person's genetic makeup or their genes affects their response to medications. Pharmacogenomics is a combination of pharmacology, which is the science of how medications work, and genomics, which is the science of the human genome. The ultimate goal of pharmacogenomics is to provide the information necessary to select the right medication at the right dose for the right individual. Pharmacogenomic tests look for variants or changes in the genes that are responsible for processing medications in the body. This often leads to additional questions, particularly, is pharmacogenomics new? Pharmacogenomics actually started or was first established back in the 1950s. Clinical genetic testing has been expanding the past 30 years because of the continued discovery of the roles that genes can play in diseases, but at times it's met with opposition because of ethical consideration. Pharmacogenomic testing has only begun to gain momentum in the past 10 to 15 years. So why is pharmacogenomics important to medication therapy? Initially, medications were felt to be one size fits all. If it works for me, it should also work for you. If you experience an adverse effect, I will too. Over time, we continue to find that not every person responds to the same to medications. In a bit, Rick is going to go into greater detail in this area. In many ways, pharmacogenomics is still a child, but just like a growing and maturing child, pharmacogenomics is gaining momentum very quickly, and we've also experienced some growing pains and challenges along the way. Our patients are beginning to know more about pharmacogenomics through the direct-to-consumer movement. At-home tests, TV commercials, news articles, and printed articles are starting to infiltrate society. The legislative and coverage landscapes are both changing significantly, especially in the past 5 years. And while there have been pain points and roadblocks for us to navigate, there have been notable advances to promote the availability and accessibility of testing to patients. The word is definitely getting out there regarding pharmacogenomics. So another question that I frequently hear is about personalized medicine. What is it and how does it relate to pharmacogenomics? Personalized medicine is a healthcare model which proposes the customization of medication treatment to each individual patient. Personalized medicine negates that one-size-fits-all mantra that we just spoke about. Pharmacogenomics is a key component of personalized medicine because it focuses on an individual's genetic makeup to tailor their medication therapy. The concept of personalized medicine was first documented in the late 1800s when a Canadian physician noted, quote, great variability among individuals. For the healthcare practitioners in the audience today, I'm pretty certain we all can recall one or many patient situations that just did not add up. One of my first aha moments occurred when I was working as a consultant pharmacist doing a monthly medication regimen review for a skilled nursing facility. A resident who is known to me had a recent transition in care. Upon her return, she was ordered a dose of an antipsychotic medication that was 2.5 times her previous dose. I was certain it was a transcription error. However, upon further investigation and confirmation, the new and exceptionally higher dose was, quote, intentional, since her lower doses were deemed not effective for her. To this day, I would still like to see her pharmacogenomic test results to see if this was potentially playing a role in her response or lack thereof to therapy. Next slide, please. Before transitioning the discussion to Rick, we would like to do a brief polling question. Are you interested in utilizing pharmacogenomics in the care of your patients or residents? So if you could take a moment and please answer yes, no, or not sure, but I'm interested in learning more. We'll give you each a couple seconds to populate your answer.
Couple more seconds and I'll end the poll for you all. All right.
Okay, we're straight down the middle. So I guess the good news is there's no no's. So as I mentioned, we'll go ahead and turn it over to Rick and he'll give us some additional information.
Great, thanks Jen for just a great presentation. So as Jen noted, and as she defined what pharmacogenomics is, perhaps this is a good graphical representation of exactly what we're talking about. What we know is that there's great variability in terms of the response to medications, and there's a lot of factors that can affect that. Other medications that the patient is on, the current disease state, certainly of the patient, as well as drug allergies that the patient may have. But also what we're finding is that there's a genetic component to that matrix as well. What we know is that there's some individuals that can take a medication and they're perfectly fine with it. Efficacy is doing what it's supposed to do, side effects are minimal. There could be another individual that takes the exact same medication and it simply doesn't work for them. And yet another individual that takes the medication may work, however, the side effects are become intolerable and in some cases become worse than the underlying disease in itself. So that's all to say that pharmacogenomics, or sometimes what we call drug-gene interactions, is not sort of in a vacuum all by itself, but rather it's one of the key factors for prescribing the medication beforehand, or I should say taking into account before the prescription as part of that criteria, which a pharmacist would call a drug utilization review. We know this because that the FDA has stepped in and over 260 medications now in the marketplace have guidance in regards to pharmacogenomics in the labeling itself. This represents over 40% of the most widely prescribed medications on the market. Next slide, please. This is backed up by a pretty impressive stack of evidence that supports the concept of evidence-based medicine. We'll start with what I just alluded to, which is regulatory review. What not only the FDA, but other regulatory agencies in other countries around the world are starting to recognize, and in many cases are starting to require such testing to be done prior to the approval of the medication in the respective marketplaces. So this is being done here in the United States. This is being done in the European Union, as well as in certain Asian countries. But there's other data sources that are also very important. The next one would be what we call consensus review. And this is where clinical consortiums, and I'll name one here, the Clinical Pharmacogenomic Implementation Consortium, also called CPIC. CPIC is an NIH-funded group of clinical experts from really around the world that ensures clinical validation and the establishment of a common nomenclature, which simply means in a common language and definitions. As we navigate through this very complex science, we have the same sort of terminology in place that allows us to speak sort of this outside language, and if I can use that analogy. But then the third layer, of course, is what we call the peer review data. And this is the literature that we find in the periodicals, JAMA, the New England, et cetera, that allows for us to have continuous improvement and understanding of new and potential applications. These, of course, would take the form of a meta-analysis, retrospective analysis, even the gold standard being the randomized controlled clinical trials are certainly applicable here. And what's exciting is that this evidence, this stack of data allows practitioners to practice evidence-based medicine so that there's very little doubt in terms of the rationale of decisions that are being made. Next slide, please. Okay. So how is this all being used in a clinical setting? Well, the first thing that we need to establish is that the testing only needs to be performed once. It's not necessarily a blood test, but rather what we're doing is we're harvesting the buccal cells from inside the cheek to get the DNA and to analyze it through our analyzers at the laboratory. It only needs to be done once really in the patient's lifetime if the data can be used and more or less recycled, or as some people would say, perpetuated through the care continuum. Now, many therapeutic categories can be evaluated. We just listed a few here on this slide, but certainly the applicability is very broad. But where we see it most used is really in what we call the top four, and which are going to be the very common therapeutic classes that we see in a given internal medicine practice: cardiology, pain management, behavioral health, and GI conditions. It's not to say that the others are not important or not applicable. It's just that these four are oftentimes the most common, and we'll build upon this in the conversation in a few slides. Next slide, please. So what does a good pharmacogenomics solution in a clinical practice entail? Well, the first component is really going to be to have the ability to identify appropriately those individuals that would benefit from the test as a diagnostic. What needs to be gathered is what we call medical necessity for the justification of the test. We don't want to test everybody, just those individuals that have an immediate need, and again, can be linked back to that evidence base. The second component is once the test is done and the results are returned, how do we use these results so that they're actionable, that a practitioner within their practice is able to take the information and very quickly make the appropriate interventions on behalf of the patient and their care. And then the third component is more of a technical component, and that is how do we integrate this within the EMR settings so now it resides in a native work environment of the customer base, or I should say of the clinical base, so that they can use this in an efficient way to, again, as they're caring for their patient. So to put it all together, I'm going to hand it back over to Jen. She's going to walk through some case presentations, and we're going to see sort of how this all sort of builds out in terms of optimizing care for the individual. Jen?
Thanks, Rick. So today we are seeing pharmacogenomics is being utilized more in some care settings than others. As we heard during Rick's discussion, its use and implementation is really agnostic. So once a patient has their PGX test results, they can be used by any provider in any care setting for medication management. The important thing to remember is that testing really only needs to be done once. As long as we're doing a comprehensive panel of genes that we're analyzing. Really, the only situation where testing might need to be reconsidered is if an individual does undergo a liver transplantation, because then the liver enzymes are changing. So something to kind of keep in the back of your head. The next few slides are going to contain two case studies. One is a patient suffering from cardiovascular disease, and the other is looking to improve behavioral health related symptoms. So go ahead to the next slide, please. So the first patient that we are going to meet is JP. JP lives independently in the community. Unfortunately, JP had a primary CV event and subsequent stent placement. In JP's case, standard of care for post-stent placement was followed. Clopidogrel was added to JP's medication therapy. JP was adherent to the prescribed medication therapy, and he also did his best to remain active. So at first glance, it looks like JP is well on the road to recovery. So what happened with JP? 6 weeks later, JP experienced a secondary cardiovascular event. This resulted in an extensive rehabilitation stay in order for him to regain basic functioning on his right side. Next slide, please. So when we think further about what happened pharmacologically, we do want to look at the clopidogrel. It is a prodrug, so that means it has to be activated by the body once it's ingested. Clopidogrel is activated in part by cytochrome 2C19, which is one of the cytochromes in our liver that metabolizes medications. When JP was rehospitalized, pharmacogenomic testing was performed at the acute care center. JP's test results indicated that his 2C19 phenotype was a poor metabolizer, which did increase his risk for a secondary cardiovascular event. So poor metabolizer designation indicates that JP's 2C19 enzymes do not function as optimally as a normal metabolizer. So any medications that are primarily metabolized by cytochrome 2C19 have the potential to be affected. In this particular example, clopidogrel was not being converted to the active form in a significant enough extent to leave, and it left JP subtherapeutic. So how would knowing JP's phenotype prior to prescribing clopidogrel therapy potentially impacted his trajectory? With JP's PGX test result information, his clinician would have started him on an alternate therapy, such as Brilinta or ticagrelor, which would have significantly decreased his risk for a secondary event. Across the healthcare continuum, we are all cognizant of preventing readmissions, reducing healthcare expense, improving outcome, as well as patient quality of life. Through this case study, we can see how pharmacogenomic test results could have had a significant impact on JP's outcomes. Rick, do you have anything additional you'd like to add regarding JP's case study?
Sure, there's a couple of things here. Number one is that this is not a rare event. Roughly 20 to 30% of the population will express that the phenotype will be either a poor metabolizer or what we would call an intermediate metabolizer, which both, and I'm going to use this word, phenotypes, impair the ability for the medication, in this case clopidogrel, to be converted to its active form. The other component here is that those of you in the audience that are dealing with managed care and insurance companies, Brilinta has not been one of their favorite medications. And I say that in jest, of course, simply because of the price of Brilinta prior to its losing its patent was in the neighborhood of about $12 per day, whereas clopidogrel, its average retail per day cost was in the neighborhood of about 25 cents per day. So the cost differential is pretty significant, and that's why many of the insurance payers, the pharmacy benefit managers, were preferring clopidogrel over its therapeutic substitution, unless justification could be established And certainly this would be part of that justification. And the last thing I'll say here, and again, is we try to be consistent in the mantra of evidence-based medicine. There was a fairly significant study that was done by Larissa Cavallari and her group at the University of Florida. By the way, Dr. Cavallari is an active member in CPIC, a group I mentioned previously. And in that study, what they were able to really illustrate for us, and what the data would suggest, is that there was a significant difference in really these subsequent cardiovascular events for patients that were seen as poor or intermediate metabolizers on clopidogrel as compared to a group that was on ticagrelor. And that difference was in the neighborhood of a 3 times differential in terms of the overall cardiovascular rate. So again, this is something that relatively is common. And I guess the last thing I'll add here is that some major academic institutions have instituted a protocol within their cath labs to offer this testing. Vanderbilt, Mayo Clinic, just to name two, have active programs in order to prevent a case study like this from occurring within their practice settings.
Thanks, Rick. So now we're going to meet Jane. Jane is a 74-year-old widow. She does reside in a skilled nursing facility. She was diagnosed with clinical depression about 6 months ago, and her PHQ-9 score was 14 at that time. Her symptoms included sadness, anxiety, and insomnia. At the time of Jane's diagnosis, she received a starting dose of citalopram, 20 milligrams, and over the course of a month was titrated up to 40 milligrams, which did not provide her any benefit. So after a taper, citalopram was discontinued and she was changed to escitalopram 10 milligrams. 2 weeks later, the escitalopram dose was increased to 20 milligrams. Over the course of these 2 months of medication adjustments, Jane showed no improvement. It was also documented that she had begun to get into verbal altercations with the staff and other residents at the facility. The addition of other therapies, such as antipsychotics, are now being considered for Jane to help manage her behaviors. So let's go to the next slide, please. Through pharmacogenomic testing, it is discovered that Jane's 2C19 phenotype is a rapid metabolizer. CPIC guidelines that Rick had mentioned earlier indicate that citalopram and escitalopram are metabolized similarly. And for patients with that are a 2C19 rapid metabolizer phenotype, they are not recommended. The pharmacogenomic information that is available to us can be used to yield a list of medications that are less likely to have interactions or negative side effects for that individual. An example of this type of list is shown to the right. As we can see, citalopram and escitalopram are not included on the list. So for 2 months, Jane's depression had not been optimally treated. When we look at Jane's case, how would knowing Jane's phenotype prior to prescribing citalopram potentially impacted Jane's trajectory? With Jane's pharmacogenomic test result information, her clinician would have started her on an alternate therapy such as duloxetine, which should provide Jane with an opportunity for appropriate treatment for her depression. We can see with Jane, we were starting to go down a very slippery slope. Lack of appropriate treatment for Jane's depression caused her condition to worsen, which was also resulting in the addition of other medications to her regimen. Upon further review, these medications could have potentially been considered unnecessary due to the root cause of use. For those of us intimately involved in long-term care, we are keenly aware of the concerns related to psychotropic medications, especially antipsychotics and quality measures. In the bigger picture, Jane's change in condition was most likely not in the best interest of the patient or the facility moving forward. So Rick, anything additional or that you would like to add to this case or that sticks out to you regarding Jane?
No, Jen, you covered it really well. I just want to illustrate the point, and the customers that we deal with and what we hear the most is that if the depression's not being treated and behavior starts becoming an issue, the behavior has to be treated. And there's really very limited good options for that to occur. What we're hearing consistently is that the communities just don't have the human resources to dedicate toward a patient that is exhibiting behavioral issues, especially when those issues are flaring at 2:30 in the morning and causing, really a very tough environment for not only the staff, but also for other residents in the community. The other is, and you alluded to this as well, is that nobody wants to see these individuals having to move to another care setting. But sometimes that's needed if behavior can't be kind of addressed and under control. And again, Jen, as your experience kind of outlined, the third option, using an antipsychotic, whether it be quetiapine or olanzapine or even risperidone, for these individuals causes a lot of issues into themselves, to which CMS is becoming very active in evaluating, and in some cases, really putting into a regulatory concern towards the facilities as well. So not a lot of great options for these kind of patients. They deserve a lot better, and hopefully that the pharmacogenomics is able to at least alleviate some of that pressure for these individuals.
Yeah, I think another thing to point out here in our first example with JP, he was a highly functioning, independent individual in the community. And then in contrast, Jane was in a skilled nursing facility. Her health condition was a little bit different, but we could see clearly where pharmacogenomic testing information could have benefited both individuals. So there's really no perfect time for us to consider testing an individual. We could see where both would have had significant impacts related to the outcomes of their care.
Absolutely. And as you would know more than I would, Jen, a lot of times these conditions sort of overlap with each other. And so it just adds to the complexity, and hopefully that, such a solution as pharmacogenomics can add a little bit of clarity as we go through these challenging individuals.
Okay, we can move on to the next slide, Sarah.
So we're going to wrap this up. We're very excited about what the future holds for pharmacogenomics. There's always new discoveries coming in with different gene variants and the improved clinical outcomes, as I've alluded to in my portion of today's presentation. The science is alive and well, and the evidence, it just continues to grow at an exponential rate. We're starting to understand the complex drug-gene interactions better. Again, there are some very top-minded individuals that are discovering new things every day, but more importantly, are bringing them to the clinical setting so we can optimize care for the individual patients and hopefully utilize our resources more efficiently. And then the last point that I'll make is that with the electronic medical records, certainly that's a must. This is a fairly complex science, as we've kind of outlined in a very short amount of time. The only way to harness it would be from a digital component and being able to reuse and perpetualize the data long term, again, all in the name of optimizing care for the individual patient and having great outcomes for them. So I think that's the last slide. So I think we have a few minutes. Holly, I'll turn it over to you, but I think Jen and I can be here for a few minutes to answer a few questions as they come in on the chat. Or I don't know, Holly, if you're going to open up the lines, but we can do that too, I guess.
Yeah, absolutely. Thank you both so much. If anybody in the audience does have a question, please feel free to put them in the Q&A or chat section below. We do have a couple that have came in throughout the presentation. Starting off, is there an ideal age when PGX testing should be performed?
I can go ahead and take that one. Rick, really there's not, as I mentioned towards the end of our case studies, we saw two drastically different situations with the case studies, different age demographics for the patients, and we saw where both had utilities. So, clearly if you test younger in life, those are test results that are going to carry with you throughout the duration of your lifetime. So If you do have medical conditions or concerns, that's a perfect time to be, treated. So you can have that before sometimes even being prescribed any medications. But we did see where even later in life, there were situations where the patient could have significantly benefited from the information we received through the pharmacogenomic testing.
Great, thank you. Next question, does any insurances cover the cost of testing or how can they be paid for?
Sure, I can take that one. So Medicare does cover this as part of plans, Medicare Part B as well as Part C. I want to make sure that's very clear. However, they do require medical necessity to be established. That would be the diagnosis of the individual patient as well as the pertinent medications to which the testing would be applicable for. For the other insurance companies, what we would call the commercial insurance, it would vary from company to company to policy. Of course, the tricky deductibles and copays would also be applicable, but certainly it is something that is becoming more accepted, and we're starting to see some more coverage decisions that are very favorable towards the testing where it is done appropriately.
And just to
Great.
chime in on that, that's great information, Rick. Just a few weeks ago, I was in Washington to a legislative fly-in. There is currently a Senate bill that is being proposed for Medicaid plans to cover pharmacogenomic testing. So, that's definitely exciting news moving forward in terms of having these types of tests accessible to all different patient demographics.
That is great. Another question, what is the turnaround time for this testing?
Sure, I can answer that. Usually a good laboratory can get the turnaround time between 7 to 14 business days. There is some complexity in terms of the extraction of the DNA as well as the quality assurance. But as we compare it to some other genetic tests that are currently available outside of pharmacogenomics, 7 to 14 days seems to be sort of on the shorter end of that continuum. And of course, utilizing the power of overnight services like Federal Express or USPS overnight, that keeps the transit time to a limit as well. And that's why we can accelerate that turnaround time.
Great. Next question, what outcomes data is available?
Yeah, that's a growing body of work. I alluded to one. The University of Florida has done a lot of work looking at clinical outcomes. Another that I'll mention here is what's going on at the University of Calgary. And so we're starting to see a lot of data being published from these institutions, as well as, quite frankly, others from across the country in North America, as well as into Europe as well. And so they're looking at not only patient outcomes, but also, where applicable, financial outcomes that would be probably very attractive to some of the institutions that have a vested interest in such.
Thank you. Next question, do you have any suggestions on how to identify patients that could benefit the most from PGX?
Yeah, so as Rick had discussed on one of his slides, there are risk stratifications that can be performed based on medication profile data for patients. So, within a facility or a specific patient population, a risk stratification could be performed. This shows you which patients are kind of bubbling to the top that could potentially benefit most. That also helps with some of that clinical necessity documentation that's needed for the testing to be covered. So we're able to show why there is a concern related to those particular patients. But that's usually a great place to start because as Rick had mentioned, it's really not that there's this consensus that everybody it needs to be treated. So this helps you, especially if you have an existing population, identify those, a good starting point.
Great, thank you. Are there any other questions from our audience today? That was the last one present in our Q&A section. So I would like to give an opportunity before we close our presentation for the day. Alrighty then. Well, thank you so much again, Rick and Jen, for providing your time and expertise to inform our members and our group. Oh, it looks like we do actually have one more question. In case one with JB, when would he have been eligible for testing?
That's
Oh,
a great question. So, as Rick mentioned, there are some institutions that are implementing pharmacogenomic testing, in the cath lab or prior to the point of prescribing. So in his situation, depending on the institution where he is at, there may be an offer at that point in time, which is, very optimal because then, there it is known from the very beginning whether or not that medication would have been appropriate for him. Through this case study, we realized that he didn't get something negative happened. There was a secondary issue that happened prior to the testing, which could have been potentially preventable at that point in time. But he could have been eligible from the point of his primary event.
yeah. And I'll make a comment on that as well. I've seen discharge protocols where a patient like JB exit the cath lab. He's prescribed Rolenta, and then a week later, as part of the follow-up visit, that's when the test is performed. They get the results back, and that if they could step down to clopidogrel, which again is going to be the less expensive medication, they do it at that point if the testing would indicate it. If the testing does not indicate that clopidogrel would be appropriate, then a patient like JB would stay on the more expensive medication going forward. So there are, again, what I would think are very strong evidence-based protocols and standing orders in place in order to optimize care for a patient just like JB to try to prevent that subsequent event.
Great, thank you. And we did get another question as well. Do any other healthcare systems globally have this as a standard of care?
Yes, there's a number of them. And so I just mentioned two during the presentation. It is being adopted simply because the evidence is so strong, it's hard not to. So I think a lot of the questions now become from a logistics standpoint, does the institution want to implement their own internal lab, or do they outsource that? And then how do they integrate that from an IT infrastructure? Once those nuances get ironed out, we're going to see a vast acceleration in terms of institutions incorporating these programs.
Thank you. We still have time for a couple more questions. If there are any more from the audience, just since it takes some time to type, I will give a couple moments here as an opportunity. There's one there for you guys. All right. Do you see this impacting guidelines? As an example, for Jane, we're supposed to give 6 weeks before changing therapies in depression.
As it becomes more widely adopted, I do see where it could potentially impact treatment guidelines. There's still much, that we're waiting to find out. At this time, it's unfortunately not widely adopted. Therefore, most of the patients we're seeing, we do not have this type of information. But yeah, I do potentially see this impacting because there are many studies available today that are showing how pharmacogenomic testing results have impacted and prevented ER visits, hospitalizations, negative outcomes from occurring. So as that type of data increases, I think as a society and a healthcare system, we're going to have to start looking closer at things such as guidelines.
All right. Well, thank you both again, Rick and Jen, for providing your time and expertise today. And thank you all for joining us for our special webinar offering with Grane Rx and Access DX. We hope you're able to log off with more knowledge and the confidence in understanding and using pharmacogenomics across healthcare settings. And I hope everybody has a great rest of their day.
Thank you.
Thank
Thank you.
you.